सर जी गुड इवनिंग।
गुड इवनिंग जी, गुड इवनिंग। क्या हाल है?
बस ठीक सर। क्लोजिंग सर हो गई कि अभी हो रही है?
वो तो गई है, थोड़ी बहुत बची हुई है, वो भी होगी अभी।
अच्छा, बराबर।
हाँ, अमित का हो गया, सोनू का हो गया, मेरा हो गया।
ओके।
दिल्ली का जो थोड़ा बहुत रह गया है, 40-50 हजार रुपये ऑर्डर सारे प्लेस किए हुए हैं।
बराबर।
थोड़ी थोड़ी देर में वो भी ग्रीन हो जाएगा।
बाकी लेटर आ गए सर इंक्रीमेंट के?
हाँ, आ गए।
चलो ग्रेट। कुछ हुआ है किसी का सर, अपना प्रमोशन वमोशन कुछ है?
इधर तो नहीं हुआ है, हमारी तरफ तो नहीं हुआ है।
अच्छा। रिएक्शंस कुछ हैं अभी, क्या लोगों के फीडबैक वगैरह?
अभी आना स्टार्ट होंगे।
हाँ।
अभी आना स्टार्ट होंगे, अभी उनको
हाँ,
उसका विद्या का ही फोन आया था।
अच्छा फोन आना चालू हो गया।
हाँ, कह रहा सर आई वाज एंटिसिपेटिंग सीनियर एबीएम।
ओ अच्छा।
चल बात करता हूँ, अभी मैं इधर बिजी हूँ।
ओके ओके।
Actions तो आएंगे ही।
कपिल सर ज्वाइन नहीं कर रहे, थिंक अमित जी का
हाँ हाँ
व्हाट्सएप
हाँ।
आया था।
अमित का व्हाट्सएप आया था, कुछ एक्सीडेंट वक्सीडेंट हो गया, पता नहीं किसका।
हाँ, पटियाला में कुछ।
हाँ। बोला था 550 पे ज्वाइन करेगा शायद।
हाँ हाँ हाँ, करेक्ट करेक्ट।
ओंकार जी ओवरऑल कैसा रहा? अभी डिबेट का सबका हो गया कंप्लीट?
अभी 31 डिबेट हो चुके हैं सर।
कितने?
31 ऑल इंडिया।
31 ऑल इंडिया। ओके।
अभी साइमल्टेनियसली जैसे आपके चल रहा है वैसे बैंगलोर का भी चल रहा है अभी।
हाँ, आई सीन, अभी किसी ने डाला है उसको ग्रुप में।
हाँ, दूसरा लैपटॉप पे अभी रंजित सर है। चेन्नई का हो गया अभी घंटे पहले, तो 4 बजे था।
हाँ, चेन्नई का ही देखा था फिर मैंने।
हाँ, अभी पांडा सर लगे उधर दूसरे साइड में।
तो पांडा साहब अभी थोड़ी देर पहले हमारे साथ लगे थे, उधर लगे हैं।
हाँ, अभी बैंगलोर।
अभी मैं और चिन्मय जी और पांडा जी टेलीफोन पे बात ही कर रहे
अच्छा, ओके ओके। अभी तो कॉमन टॉपिक है फिलहाल बात करने के लिए।
थे। नहीं नहीं, वो चिन्मय को थोड़ा ज्यादा रहता है।
किसको?
चिन्मय को
हाँ 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 हाँ।
जब ऐसा कुछ मौका होता है तो चिन्मय को थोड़ा रहता है।
एक सेकंड ना सर, एक सेकंड।
हाँ जी। सर गुड इवनिंग।
Hello, good evening.
व्हाट यू सर?
कैसे हो? Good afternoon. Good
या
evening.
या आई एम गुड सर, आई एम गुड। आप कैसे हैं सर?
सब बढ़िया बढ़िया बैठे हैं. Everybody is now talking, thinking, dreaming of COVID. When will it go?
यस
And
सर, यस सर, यस सर,
really be out of this rut, isn't it?
यस यस सर, certainly certainly sir. How is the
Yeah.
COVID in Chandigarh now, sir? Is it
So
decreasing now?
it has shown a little downward trend,
Okay.
better than what it was a week back.
Yes sir, yes sir,
Positively, yeah, less. बीच में तो बहुत बुरा हाल था. Things were
yes sir, yes sir, yes sir.
absolutely grim and scary.
Certainly
So
sir. In between of maybe 20th of April to maybe May 10th, it was horrible sir.
very, very bad, very bad. I mean, in our family, friend circle,
Yes sir.
a lot of casualties, a lot of people dying, a lot of people have suffered a lot. I think things have been real bad. Never seen such time, such kind of, disease or whatever calamity of any of that type. I think we've never seen that. That's been terrible.
Certainly sir. Certainly,
Yeah.
certainly.
देखो अब आगे how things go further and future, है ना? Let us
Yes sir, yes sir,
hope
yes sir.
that the vaccination is done in a big way. I think that is the way,
Yes sir.
only way to get out of it, and that should
Certainly.
be the priority. I mean, government, all the agencies, all the things, we
Yes sir,
should
yes sir.
speak in a very consolidated way to take this forward. Otherwise, I think
Even sir, our company as Alchem has taken a firm decision that they would not disburse the salary for June month till the time all the people will take the vaccination. For that, they have already taken maybe a tie-up with maybe Max Hospital and Fortis Hospital in that way. Just like in Delhi, tomorrow is a vaccination drive in Delhi, sir. So like all Alchem people will go to Max Hospital and they will show their ID card and they will get vaccinated.
no, I think that has to be done by all the kind of organizations and various groups, and somehow it has to be. But the main thing is the vaccine should be available. The numbers should
Certainly,
be.
certainly.
If the vaccines are there, then only the whole lot of people will get vaccinated. And we
Yes, sir,
have
yes.
to have numbers and kind of. I was reading an article. There can be an ordinance or a law that you have to take it.
Certainly, sir.
If you can have laws on multiple insignificant things and stupid things, we can have a law on something much more serious and relevant.
Certainly,
And
sir,
if you
certainly.
don't, then you're done. So there's no question of anybody not opting out or all. It is not for you. You spread to others.
Certainly, sir.
It's a question of not saving yourself. You are a spreader. Once you get it, then
Certainly.
you get to 20 people more. So it's a hazard.
Yes,
The
sir, yes,
government has to think in those terms and make it ultra compulsory.
certainly,
And
sir.
there's no question of not doing this or that. It has to be done sooner. This is the time limit. You don't do your fine or your penalty, monetary penalty. एकदम line पे आ जाएंगे सब.
Even, sir, I suppose that vaccination program should be ahead of maybe aside of that local politics.
Pardon? The vaccination
program should, yeah. Matlab, no local politics should be involved in that vaccination program. That is that's a separate thing, sir. That can be done, but at the same time, vaccination should be happen.
बिल्कुल, absolutely true. It has to be. Vaccination ही करेगी जो करेगी.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Not going to be of any use.
Even, sir, the doctors like you, they have given the study, they have given the guidelines. Doctors, or maybe the people who have taken the 2 doses of vaccine, they were not into ICU, or maybe they were not in, maybe into serious condition. So that data itself is a
बहुत जान बचाओ यार अगर हो भी जाता है.
Yes, sir.
If you get a kind of exposure, but you still have a much mitigated disease, much milder disease, and that is good enough. So that is good enough. I think we should.
Yes, sir.
चलना तो चाहिए. बाकी तो I think time will tell, है ना?
Certainly, sir.
So
we will start strict by maybe 6, sir. We are anticipating maybe Dr. Gagandeep, Dr. Kapil, and Dr. Ashish to be joined in next 2-3 minutes, sir. So we will sharply start by 6, sir.
When people join, let me know.
Certainly.
So I'm there, and as it goes and we do,
I will recall you, sir. I will recall you.
Okay.
Yes.
सर ये स्लाइड्स बैकएंड से मैं करूँ शेयर की
that will be better.
Okay. Good evening, Onkar here, sir. How are you, sir?
Sir, Mr. Onkar is from Mumbai. What he is saying ki, should he maybe present the slides from the?
If I will share from my side, then I won't be visible. I think
Okay.
He can continue doing, and I'll keep telling move next.
Certainly.
Okay,
Yeah.
we'll do that way. No problem.
Yes, sir.
Yeah, sure. And that should be okay.
Yes, sir.
Sure.
Sir, I just checked. Dr. Singhal is joining in a moment, and Dr. Kapil Khetri and Dr. Gagandeep will join in 5-10 minutes, sir.
जब भी आते हैं तो ठीक है. We will go ahead and see how things go.
Yeah, Kapil sir, good evening.
Hello, good evening.
Yes, sir. So we'll start just waiting for Dr. Gagandeep and Dr. Ashish Shinghal to be joined. Dr. B.S. Bhatia has already joined. He is on the platform. So maybe in another 2 minutes we will start.
Actually, you might choose me in between. I'm driving back from hospital, so
Okay.
Just carry on. I'll participate in this.
Certainly, certainly. Ashish sir, good evening.
Good evening, Mr. Sachin.
Yes, sir. Sir, Dr. Kapil Chhetri and Dr. B.S. Bhatia is already on the platform. We are just waiting for Dr. Gagandeep to join, or maybe we can start. I will just ask the permission from Dr. B.S. Bhatia. Maybe Dr. Gagandeep will join in between of also.
Yeah, we can start. There's no issue at all from my point. My view.
Yes, certainly, sir, certainly. Because Dr. Gagandeep is saying that he will join in next 2-3 minutes.
Doesn't
We can-
matter.
Okay.
We can take off. Yeah.
So, sir, I will introduce yourself and the panelists, and after that, I will hand over the session to you, sir.
Sure.
So, good evening to all. On behalf of Alchem Laboratories Limited, the India's 5th largest pharmaceutical company, I, Sachin Tiwari, welcome our eminent moderator, panelists, and all the doctors who have joined us for today's anti-thrombotic update. At Alchem, it has always been our endeavor to partner with the healthcare professionals, and we continue to do so. To help us navigate through the meeting, we have with us renowned. Yeah, so to help us navigate through the meeting, we have with us renowned physician and cardiologist, Dr. B.S. Bhatia, who is the chairman of Bhatia Heart and Diabetic Care Center, Chandigarh, who will be moderating the session. I also take opportunity to welcome our eminent panelist of today's program, Dr. Gagandeep Singh, DM Card, IVY Hospital, Dr. Kapil Chhetri, DM Card, IVY Hospital, and Dr. Ashish Singhal, DM Card, Life Care Hospital, Rohtak. So with that, I hand over the session to Dr. B.S. Bhatia, our moderator. Over to you, sir.
Right. Thank you, Omkar. And I think we have a very interesting discussion on the annual. And I think we should be, sort of getting into. We start with the first. We are going to have 2 sessions, and it's an interactive debate. I don't know how we'll keep moving, and the duration would be 1 hour, if I'm not wrong. Is it the whole exercise? Omkar,
Yes,
is it
sir.
true?
Yes, sir. 1 hour. Yes, sir.
Yeah. So I think we will start the initial, thing. This is with the anti-thrombotic debate, and primarily focusing on NOACs. And I think this would be the first one, if I'm not mistaken. No, first one is with the anti-platelet agents, and then the focus would be on law, how it sort of has a place of pride in the current scenario in the coronary events. And I think it is a case-based approach, and I think we continue. I start with the case. 72-year-old male came to the emergency department complaining of chest pain of 1 hour duration, typical cardiac pain. He's a smoker, non-diabetic, has hypertension history, and extensive inferior wall MI on ECG. His cardiac biomarkers were positive, BP and pulse were normal, and he was possibly ready for intervention. Next. And you can see the ECG clearly showing a inferior MI and lateral extension of the lateral MI. And that is the picture of this patient and treatment plan. Next, yeah. And the plan was to have PCI to the proximal right coronary artery, PCI circumference stage procedure has true drug-eluting stents, and this is how the course of action is. Now is the question, which antiplatelet to use and dosage and duration. And these are the options: aspirin lowering dose with clopidogrel 300 milligram, aspirin lowering dose with clopidogrel 600 milligram, aspirin lowering dose with prasugrel 60, or aspirin lowering dose with ticagrelor. Now I'll bring forth the cardiologist into picture. Can we start the discussion? What is the viewpoint, Dr. Ashish Singhal? What are your take on that?
I think there is no confusion in my mind to selecting the antiplatelet along with aspirin while giving a loading dose. My first and only choice will be ticagrelor. Reason being multiple. First of all, it's an agent which has a good potency over the clopidogrel and even superior than prasugrel. Second, it's been a reversible agent. Third, the drug can be given not only in a patient who was meant for PCI, even
Sorry, Ashish, could you be a little loud? A little loud.
Can you hear me, sir? Can you hear me?
Yeah,
Right.
better.
Actually, the drug ticagrelor can not only be meant for the patients who are subjected or meant for PCI, rather it can also be given in patients who are managed on medically basis, as well as who are meant for CABG in future. So this is a drug of choice. Even those who are going for thrombolysis, this can be given as a drug for loading purposes. And even the drug does not have that much of side interactions with other drugs as compared to the clopidogrel, which has a CY3A for metabolism. So I think ticagrelor in all respects will be the first and only choice in such.
That's all that. So thank you for your viewpoint. Dr. Gagandeep, has he joined, or Dr. Kapil Chatri, whosoever is available?
Sir. Sir, I'm here. I'm driving actually. Can you hear me? Good evening.
Yeah, we can hear you. Is it Dr. Kapil?
I'm Dr. Kapil.
Right. What is your take on that? Oh, Dr.
Right, sir. Ashish, I don't know why we have a choice between both prasugrel and ticagrelor in this particular patient, because it is very clear on ECG that he has an inferior MI and he is going for intervention. So later, CABG and all those things in this particular case does not arise. But more or less what you said, ticagrelor probably drug of choice these days.
Fine, I think we'll go further. The choice is ticagrelor, and why so? Next.
Sir, if you allow me, can I just answer to the Dr. Kapil?
Yeah.
Yes, Dr. Kapil, you have rightly said that prasugrel can also be given in such cases who are meant for PCI. But again, the trial which we have specifically look into, they have shown the efficacy of ticagrelor particularly is more better, except the ISA React 5 trial, which is the latest in publication. But only the rest, the plateau trial and the trials which is done with the prasugrel, the efficacy of the ticagrelor is around 2% better in terms of relative risk reduction than prasugrel. That's why I would be more leaning towards ticagrelor.
Yeah, I think that the trial you were mentioning was presented 2 years back at the ESC. I was there, and that was a short trial where prasu showed a little advantage. Coming to the next, treatment of acute coronary syndrome, and the plan is very clearly obvious how we go. In STEMI, we do antiplatelet therapy, anti-ischemic or anticoagulant, if in the window period, thrombolytics or PCI, CABG, but in unstable angina, non-STEMI, the choice would be the medical therapy would be same, but you'll choose PCI or CBG, and then long-term medical treatment. Next. So these are the few ways the platelet inhibition is done. Aspirin effects on prostaglandins, thromboxane A2, and the anticoagulants, the newer ones, either could block thrombin or 10A, and then we know the clopidogrel, prasugrel group does affect I12 receptors, and the other ones practically we will not discuss, and this is the way they do. Next. Now, P2Y12 receptor biology and existing antagonists, and the two groups, biochemically, phenopyridines, first generation clopidin, second generation clopidogrel, third generation prasugrel, and biochemically different is cyclopentyl triazolopyrimidine ticagrelor, which tends to be a little different biochemically. Next. Now, potential limitations of clopidogrel. This will be the point we are going to discuss. And it is a prodrug and requires a metabolic activation. It has a moderate overall levels of platelet inhibition up to 55%. And the most important, high variability response with a population about 25 to 30% with a very low levels of platelet inhibition, possibly what we call as clopidogrel resistance. And slow onset of antiplatelet effect, you have to give a very high lowering dose. And then the most important, it's an irreversible P2Y receptor binding. By any chance you need to reverse, then you have to give a platelet replacement to replenish the blocked platelet. Now here we take a question. Dr. Kapil Chatri is there, or Dr. Gagandi? Who takes the question?
Good evening, Dr. Gagan here. Yeah.
Good evening, Dr. Gagan. What is your, you agree with all these points?
Yes, sir, definitely. I mean, clopidogrel is still one of the most widely used drug because of the, cost that is affected. But definitely, I mean, resistance is one of the important problem with this drug, and a lot of patients, they come with stent thrombosis later on. So, because of the cost, this is being used, but still nowadays, ticagrelor or prasugrel are the preferred drugs because of these problems which we have with clopidogrel.
Right. So
yeah, Gagan.
Yeah.
Hello.
Yes, sir.
Dr. Gagan, I think these days, unless somebody has hypersensitivity or some other issues or, age, clopidogrel in primary PCI less, unless you don't have it in cath lab or some other reason of some reaction or bleeding disorder or, maybe age. We are still going to go with either ticagrelor or this prasugrel.
Dr. Kapil, any kind of addition to that? Right, then we move further. Next slide, please. Now we know clinical outcomes with clopidogrel. The various, clopidogrel resistance has given increased MACE with non-responders. Various studies here clearly showing in all these studies that there have been adverse events because of this particular point. Next. Yeah, and this is what clopidogrel does, and that is the reason for thinking otherwise. It goes slow initially, so we need to increase the speed of onset of the, effect, and then decrease the variability as shown, and then increase level of inhibition of platelet aggregation. All these are the flaws with clopidogrel, and that, if we can address, would be a better option. Next. Now, this is where we come. Ticagrelor, oral antiplatelet treatment for acute coronary syndrome. It's a direct-acting P2Y receptor antagonist. It is nothing like clopidogrel had, was a prodrug, had to be converted. And direct-acting does not require metabolic activation, faster onset of inhibitory effect on P2Y12 receptor than clopidogrel. We wanted to make it faster. And then, very important, it has a reversible binding on the ADP receptor, active in systemic circulation throughout dosing interval, higher and more consistent platelet. So faster acting, higher inhibition, not a prodrug, action is very quick, and that is where it scores. Next slide, please. And this in a graphic pattern we see. Next, please. Next slide. Yeah, and this is where the ticagrelor, vis-a-vis the previous slide of similar type with clopidogrel, the onset is quicker, and various studies have shown onset offset in the beginning, phase 3 trials, disperse 2, and increased levels shown in all these onset offset, disperse 2, and respond. All these. Now the panelists, Dr. Kapil is there?
Yes, sir.
Yeah, what is your take now with all this, being shown? How much are you convinced, and what kind of value you give to all this?
Sir, if we go by the there is still little bit distance to cover. If we have to take a call between Prasugrel and Ticagrelor definitely better option. Most of the circumstances, especially with acute coronary syndromes.
Good. So, Dr. Gagandeep?
So I also, compared to Clopidogrel, these two drugs are definitely better. To choose between them, though Prasugrel has been shown in some studies to be better in diabetic patients, but for acute coronary syndrome, Ticagrelor is the maybe a better choice.
Ashish, Dr.
Diabetic
Ashish?
patient maybe.
Yeah, thank you, Dr. Ashish.
All the data which has been shown in the slide, sir, is absolutely correct. We have already seen the efficacy of Ticagrelor, which has significantly reduced the cases of stent thrombosis. Can you hear me, sir?
Yeah, a little
Hello?
loud.
Can you hear me?
Now better.
Yeah. Already we have seen the efficacy of Ticagrelor. It has been established that it has been acting very fast in a good potent manner. The cases of stent thrombosis after the usage of Ticagrelor has gone down serious in a significant manner in our cath labs, and we have already seen that Ticagrelor in multiple trials even do have efficacy during the fast onset of action, persistent duration of action, and without much of an interaction with other drugs.
Right, thank you. Next, we move to the next slide. Next, please. Yeah, this is a clinical pharmacology comparison of all the three, and you can clearly see how they belong to which class. This PTPT, and then reversible inhibition with P2Y2 with Ticagrelor and not with the others, and then variability due to the resistance because of the genotype. There with Clopidogrel, the resistance, not with the other two, and then dosing once with Clopido and Prasu, whereas twice daily with Ticagrelor. Mean inhibition of platelet aggregation much superior in half an hour, 41% with Ticagrelor, 31% with Prasu, and very little, 8% with Clopidogrel. I think that is the reason, one of the slow action it does, because it has to get converted from prodrug to mean inhibitory platelet inhibition of platelet aggregation at 2 hours. That was half hour. Is 89% with Ticagrelor and almost close by Prasugrel 80%. But Clopidogrel way behind at 2 hours. Next, please. So the famous trial, you all know that Plateau trial, Ticagrelor compared with Clopidogrel in patients with acute coronary syndromes, the Plateau trial, and these patients with acute coronary syndrome, the two drugs were compared, and let us see what was the next, please. Yeah, you can see the management strategy in emergency room, and initial ECG, which will show one of the three, ST elevation, non-ST elevation MI, or unstable angina. We would by all, start an antiplatal therapy, and then would be invasive catheterization, laboratory, determine CV anatomy, and depending, stop antiplatal therapy, and then you will manage according to the anatomy, situation medically or PCI or CBG, and then continue antiplatelet. So that is the plan we all follow, and then we see what goes further. Next, in Plateau, what happened? The next, please. Yes, in Plateau, you can see the one graph of Ticagrelor. It was, I think, they have removed at the early part at 1 month. Also, there was a benefit with Ticagrelor. It was there at, I think, 4 months, and then definite, hazard ratio of 0.84, 16% risk reduction with Ticagrelor versus Clopidogrel in composite of CV death, MI, and stroke, the 3-point MACE. So clear-cut, advantage with Ticagrelor. Next, please. And then the sub-study of Plateau, Plateau invasive, which was published in Lancet, it showed stent thrombosis with both and definite, probable, or possible. All the three categories were with less with Ticagrelor. You can see the values very clearly. Clopidogrel showing more stent thrombosis, and they're all, significant statistically. What are your comments on stent thrombosis, Dr. Rashid Singhal? With these, using these molecules and your experience and what you think about this?
Already well known, sir, the usage of ticagrelor has reduced the incidence of stent thrombosis significantly. Especially, we try to give therapy for at least for 3 months, where the incidence of stent thrombosis is maximum in a post PCI patients. And even in hospital stent thrombosis, I think we have not seen any cases of stent thrombosis so far in last 2 years after extensive usage of ticagrelor in our hospital. So ticagrelor has a well-established action. The point in favor of ticagrelor is that faster onset of action. It has an antiplatelet activity reaches within 30 minutes, and even if a case crashes in a cath lab, immediately we load the patient and the effects start within no time. So
Dr.
it
Gagan,
prevents stent
please.
thrombosis very efficiently.
Yes, sir. So most of the patients who are coming with acute coronary syndrome, I mean, they're taken for primary angioplasty and they have to be loaded on the table. So definitely ticagrelor, because of its faster onset of action and direct acting drug, the chances of doing the procedure, the thrombosis, that has gone down, and definitely the incidence of stent thrombosis has decreased significantly after the use of this drug compared to clopidogrel. So the hardware which is being used nowadays and stents, they have also contributed a loss. But I think ticagrelor definitely it has significantly reduced the incidence of stent thrombosis.
Excellent. And Dr. Kapil, what is your take on that?
Sir, I agree with both the young gentlemen. At the same time, I would like to add that stent thrombosis incidence, because operators are handling more of primary PCI, one reason experience. Other is, like I said, better results, optimization, good stents, then the antiplatelets, of course, and proper heparinization. So experience also and handling the volume, it does matter.
And optimization. Very well said. All these would also be there, though antiplatelet action of the drug and its quality is going to be very, very important, but other factors do play a part. Thank you so much. Next slide, please.
Right.
So, time to measure bleeding in plateau, ticagrelor and clopidogrel, you can see hardly any difference. The p-value 0.434. So, the bleeding incidence, ticagrelor and clopidogrel, though a little, just about 0.32 difference or 38, and of not major consequence. And this was very good because ticagrelor, though had shown, I will show you the graph, a little more in certain situation, but not the major bleeding. Next, please. And we come to that trial, which is very interesting trial called Pegasus trial from the TIMI group led by Bonacca. Efficacy and safety of ticagrelor over time in patients with prior MI in this group. This is a very interesting trial in which they say a patient post procedure and somebody who's had an MI, should we go for a dual antiplatelet therapy? And they carried it on for 3 years with 2 different strengths of ticagrelor, 60 BD and 90 BD. And what happened? Next, very interesting data and very interesting trial too. Next, please. This trial was a 21,000 patients randomized, double-blind, placebo-controlled parallel group study in which, as I said, 90 milligram twice ticagrelor, 60 milligram twice ticagrelor administered with 75 to 150 milligram of aspirin were compared to aspirin therapy alone. The primary endpoint was composite of 3 major MACE points: CV death, non-fatal MI, non-fatal stroke, and secondary endpoint CV death and all-cause mortality. Next. And see the difference, very clear cut. This was follow-up for 33 months, and the patients had an clear cut difference. The events 9% versus 77.8%, both the ticagrelor strength, and that was a significant difference. Next, please, in the 3-point MACE, and you can see the relative risk reduction of 15 or 16, same with both the arms. And why we'll choose one of the arm, we'll go further. Next, please. Now, this is where, the TIMI major, TIMI minor bleeding, less with placebo, more with ticagrelor, more with 90, less with 60, and then fetal bleeding. But the major bleeding, ICH and fetal bleeding, if you clearly see, not much of a difference. So not of much severity. But if you take ticagrelor 90 and 60 BD, overall 60, the results, positive results in 3-point base were similar. And bleeding is less with 60. Next, please. 60 BD. So we'll not go to the guidelines. We'll first discuss Pegasus trial, if anybody wants to make a comment on that. So, and then this has gone for 3 years, 33 months, a new concept on stable, coronary vascular stable disease. So chronic kind, how you take that and how you practice in your practice, Dr. Ashish Singhal.
Yes, the Pegasus TIMI 54 has clearly shown the benefits of containing ticagrelor beyond 1 year in a post-PCI patients. And yes, we do practice, start writing after this trial, the continuation of ticagrelor therapy beyond 1 year. But sometimes the patient is more apprehensive in Indian scenario. They are more concerned about the amount of tablets they are taking, as well as the expenditure they have to bear upon their pocket while continuation of therapy, especially the patients when they are poor, so they are somewhat resistant in continuation of therapy beyond 1 year, especially ticagrelor. And even some counterpart physician cardiologists, they are now difficult to convince because they belong to an old era, so it's difficult to continue in current Indian scenario. So that's
good.
what we have hindrances in our current practice. But again, we understand its importance, that the efficacy of the drug is not at all doubted in prevention of ischemia.
Jagandeep, a brief comment. Dr. Kapil, a brief comment. Whosoever takes first, please.
Yes. So regarding Pegasus, I mean, it has shown that continuing this drug beyond 1 year, which is the recommended time for dual antiplatelet therapy. But I mean, that is, as Dr. Ashish said, cost is one of the important factor to continue this drug for so long. But there are certain group of patients who are at very high risk of ischemic events, like patient who had multiple stents or stent thrombosis, and maybe a left main or bifurcation lesions. So these are the high risk groups in which these should be continued